Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and I'm delighted that my guest this week is Professor Dame Lesley Regan. Professor Regan is Professor of Obstetrics and Gynecology at Imperial College London and Honorary Consultant at St Mary's Hospital. She was the President of the Royal College of Obs and Gynae from 2016 to 2019, only the second woman ever to hold this position. In 2022, she was appointed as the government's first ever Women's Health Ambassador for England. She's also the chair of Wellbeing of Women, the only UK charity that funds research, advocacy and education into every aspect of women's health across the life course. Welcome to the podcast, Lesley.
Thank you, Rhiannon. Lovely to be here.
So when the government launched the Women's Health Strategy in 2022 and announced your appointment as the Women's Health Ambassador for England, you said that you saw the role as an opportunity to get it right for women and girls. So I'm going to jump straight in and ask you, what do you think it looks like for clinicians and for society as a whole to be getting it right for women and girls?
Thank you, Rhiannon. Well, that's a big question.
It is.
I think that women and girls have been disadvantaged for a very long time. And that has come about for all sorts of reasons, but primarily, I think, because of the way we've structured the NHS and the funding streams. But most importantly, I think the profession has to take a little bit of a responsibility for this. I think we've tended to forget what the common things are that really affect women's lives across their life course. And we've focused on very sophisticated interventions and great innovations, all of which I welcome. But we've got to remember that when you and I go to see healthcare professionals, for the majority of times across our life course, we're not actually sick. Women are usually going because they need help maintaining their health or they need help with common everyday problems. Remember also as well that women are really the custodians of health for the family. One of the things I always say is that when we get it right for women, we get it right for everybody else in their family, their community, and in wider society. We're not just 51% of the population, but we're half of the workforce now. When we come to the NHS, and this is who most of your audience will be, that's really important because the NHS remains the largest employer of people in the whole of Europe, 1.5 million people, and nearly 80% of them are women. So if we only just got things right for women in our workforce, we would actually be able to maintain them, retain them, and get the best out of them. But to return to your question about what the issues were, I wanted to introduce the idea that we should be looking at women's health across the life course. And this came from lots of interactions I had with policymakers and politicians during my time in national leadership roles. You mentioned at the RCOG and various other things that I've done over my career. The realisation that actually most Secretaries of State for Health and Social Care have in the past viewed women's health as maternity. And they've forgotten, or not forgotten, or perhaps no one's really explained to them that pregnancy is an interval in a woman's life. And because you and I are going to live for so long, it's actually a very short interval. It's a very important one. And the outcomes, of course, are very, very dramatic when they go wrong and wonderful when they go right. But it's only about 2 or 3 years of your life that you're going to spend pregnant. I have twin daughters. I'm privileged. They're in their 30s now. Well, I was pregnant for less than 9 months of my life because they were born premature. But that's another story. So I really think it's important to think about it. And it's actually menstrual health that's really important. There's nothing else that happens to you and I more commonly than having 12 periods a year for 40 years of our lives. And every one of us who menstruates is going to become menopausal. So much of women's health needs are predictable. So to have a situation where they don't know how to deal with them, or they're surprised by what's happening, or they're disabled, is an own goal. It just makes no sense whatsoever. Those reproductive years are very important, but actually you and I are now going to live for a long time post-reproductive. And we've not really addressed the main health issues there. So I think sometimes the people who I've annoyed or irritated by going on about all the things that we should be doing for women will say, yes, but what about all the other things? And that's exactly my point, that I have a particular, if you like, practical knowledge of how we can get all that stuff in the reproductive years streamlined. But my main aim is to do that so that women are not disadvantaged by their health or the lack of maintenance care. and that we can then provide them with more efficient services with much more cost efficiency as well. I think we will basically save an enormous amount of cash and resource that we can then plough into the 50 plus years and ensure that we have properly funded the research and innovations needed to cope with the three things that are going to kill you and I. And I don't think they're going to be cancer for the most part. They're going to be cardiovascular disease, the complications, very important in women, of osteoporosis and frailty. Most women we talk to down the street don't understand that their bones become more and thinner, and they become more frail in the menopausal years. And that if we don't do something about that, they lose their independence and their ability to just get on with their lives. And the third killer, of course, is dementia. And the other important thing to understand, I think, is that all three of those big topics that are going to be so important for the next generation of women, because they're going to live so much longer exposed to those potential risks, is that we've got to think about ways in which we can't eradicate them necessarily, but we've got to postpone them so that women have the shortest interval of poor health to live through. So at the moment, I think there are many myths about women's health. And one is that they live longer than men, so they're healthier, but that's not the case. They spend a much longer interval of their later years in poor health. And we know that we can postpone that quite significantly if we educate them to know what they've got to do. And that is something I think is really important, that we understand the power of explaining and providing women with the information and the tools they need to do the best for themselves. Now, I'm not putting the responsibility back on women. I'm just saying that one of my regular observations about women over the 40 plus years I've been looking after them is that when you tell them what you think they need to do to help themselves, not only do they usually follow the advice quite carefully, but they don't keep the information to themselves. They share it with everybody else. We need to adopt this life course approach because actually that's how our bodies function, and that there's so much we can do to improve women's lives by listening to their symptoms and providing them with easy access to the things that they need, and preferably in a one-stop shop wherever possible. I don't think you mind travelling to come and see me if you know that when you get there, you're going to get your smear and your mammogram and your problem periods or your contraception and or your HRT or your menopause or your urinary incontinence problems in later life all sorted, together with advice about ensuring that your blood pressure is normal and that your cholesterol is not too high, etc., etc. I mean, wrapping services around women rather than making them run around the different services is cost efficient and it's beneficial for everybody. And one of the other myths I think about women's health is that it's going to be the expensive stuff, or the problems are all at the end of life. And I think the McKinsey data that were published last year, very powerful to show that actually women's productivity in the workplace, both in the paid economy and in the unpaid caring roles that they undertake, is very, very important between the ages of 20 and 50. It's not all concertinaed or packed in, rather, I should say, into the latter years. And as I say, my interest in getting the reproductive maintenance stuff right is so that we can then turn our attention to the major killers of women and the things that disable them. And we now know, for example, in cardiovascular disease, that women's symptoms are very different. And they're often dismissed when they're having a heart attack because their symptoms are not the classical central chest pain and the angina pain going down their left arm. They're often told that they're being hysterical or they're just tired or they're stressed. And then, of course, one of the other things we've identified as well is that the interventions for cardiovascular disease, which is a major problem, 52% of the deaths of women this year in this country will be from heart disease. Most of the trials, both the intervention trials and the drug trials, have been undertaken in men. And women, where they have been included, have not been of reproductive age because they are a bit more complicated. Well, that's it. We are a bit more complicated. And I think hopefully we're going to be able to change that emphasis now. I often say what I want to do by the end of this women's health strategy is to reset the dial so that we can provide them with access to the things that they need.
You were just finishing off then talking about access, and you touched on the idea of a one-stop shop and efficiencies, and that leads me on to my next question, which was about what have been the main achievements of the Women's Health Strategy so far that you're most proud of. And I thought we might talk a little bit about the Women's Health Hubs as part of that.
Well, firstly, I think that there is a strategy is great. If you've managed, or any of your audience have managed to skim read it or look at the executive summary, it's a very aspirational document. It was describing what the problems are, but it didn't have an implementation plan. And I think that's what I was appointed to try and help facilitate. And as I say, progress has been slow. I mean, I'm coming up to my 3rd anniversary in the role in June of this year, but we have made really quite concrete progress, I think. So that, I think, is important. We've improved the information that women get, and we base this on the 100,000 responses to that public consultation, which were shocking.
Yeah.
Absolutely shocking.
I remember it, yeah.
80% of those 100,000 women said, we have been ignored, or we've been belittled, or we've been dismissed. So the information is better. I would say that the NHS websites are not the sexy interactive ones that possibly my daughter's generation are immediately drawn to, but they are a lot more informative and comprehensive than they used to be. And there is now a women's health section on the NHS website with over 100 separate areas that they've addressed. And although the format is very much a government website, they do now have links to all sorts of other things, to videos, to infographics. There are opportunities and links to other things. And I think that's a big step forward. I wanted to introduce the Women's Health Hubs because I felt that this was a way in which we could wrap the services around women. Of course, that's taken time. And there's always argument about, well, we haven't got enough resource to do it. My response to that is, well, actually, the pilot studies, and I'll come on to the different models, pilot studies that we've done on the varying models have demonstrated that these are so cost effective and so beneficial, not just in terms of money saved for the system and better outcomes for the women at speed, but also because they're a really good workforce retention tool, because surprise, surprise, people like you and I like to work in a system that says, okay, Rhiannon, we can do that. How about we book you in for this appointment and we do all those things in one go? And they're also a very good way to train people, because I meet many individuals in primary care who say they can't insert Mirena devices or do minor procedures because they would have to backfill their surgeries, which I entirely understand because they've got to go off and have training. But you spend a couple of days in a women's health hub and you will learn very, very quickly about all these things, because we're going to we're going to do them at volume because they've been carefully triaged. And then the other things that we've achieved, I mean, we've got big things with the baby loss certificates. It's a small thing to some people, but to the women and the couples and the men who've lost babies and not had their loss or their bereavement recognised, this is a major thing. So the certificates are not a legal document, but they are a physical. You can download a copy of the certificate with your baby's name on it if you want. They are an acknowledgement of what has happened if your baby didn't reach 24 weeks of gestation, which is the legal definition of when you register a birth or a death. And the HRT prepayment certificates were also a big boom. For the last nearly 2 years now, women have been able to access a 1 year's supply of hormone replacement therapy for the cost of a single prescription. The website crashed within hours of when it was launched, which I was really thrilled about. Everybody said, oh my God, look what you've done.
Indicated, yeah.
Marvellous, absolutely marvellous. And the tech guys got all sorted out, and it was all great. But, when I do some travelling around the integrated care boards, there are now 42 integrated care systems or boards around the country. Many of those healthcare professionals, particularly in the northeast and the southwest and northwest, they're telling me that those HRT certificates have been the difference between women who were never able to access HRT and having their lives changed as a result of it. So, we've done a lot of work in the workplace. The Department for Work and Pensions now has a menopause champion. And I think we've got a lot more understanding about the things that we can do to make women's lives easier and allowing them to continue in the workplace. But the hub models, I think this is really interesting, because 2 and a bit years ago when we first started mooting the idea, well, a lot of people got very upset. But we want to collaborate with primary care and we want to collaborate with secondary care, but we've got to have a left shift into the community, away from the hospital disease model and towards the community and prevention and access to maintenance health model. And I don't think that it would be realistic of me to say, well, we're putting it all back into primary care. They are overloaded, but we want to work with primary care and those GPs, practice nurses, community clinicians who are interested in this. And we want to say, well, come and join us in this venture whereby we work out a way to deliver good health closer to home, and that we prevent so many of the women waiting unnecessarily on long waiting lists for long periods of time, unable to contribute or get on with their lives in the meanwhile. So when I say the different models, some of the virtual triage models have been revolutionary or transformational, shall I say, where you have all the referrals that would have gone to a hospital or a gynecology clinic, shall we say, triaged in a central point of access, and then you work out where they need to go to. Going back to my point earlier, I don't suppose you mind travelling if you know that you've got to the right place. What's so frustrating is when you get there and say, oh, we can't do that here. So the virtual models that can often sort things out, because a lot of women desperately need advice and guidance about what to do. They need signposting to websites or pelvic floor exercise apps or dietary advice, or they need advice about how they can use ibuprofen, which is available in every pharmacy, to help with their painful periods, all sorts of things. And then we may have a virtual consultation, and I think, okay, so Rhiannon, I think what you need for your painful heavy periods, because that's going to upset you 12 times a year, we need to fit you with a Mirena device. So this is a contraceptive device. So if we need you to have one of those, then you need to be able to go to a centre it's got people who can fit that painlessly, because we don't want any painful procedures. Or alternatively, say I came to you and I told you that I'd had some postmenopausal bleeding. It's really not very sensible for me then to wait on a waiting list, even if I get onto a 2-week rapid referral waiting list for query cancer, to then have ultrasound scans and lots of blood tests and follow-ups. And this could take several months anyway, because we know that the gold standard for postmenopausal bleeding is we've got to get a sample of the womb lining, of the endometrium, to ensure that you haven't got anything sinister going on. So rather than go through all those time-consuming and resource-consuming steps, let's direct you straight towards one of the clinical diagnostic centres, and we're collaborating with them as well, who are able to undertake a hysteroscopy looking inside with a small telescope and a biopsy. We've also got all sorts of hub and spoke models where you may need to have a particular investigation or some imaging before we can plan the next step, and also mobile hubs. So in disadvantaged communities and marginalised communities, we found that the mobile hubs that actually are moving around, often in converted buses and things like that, are doing wonderful things for homeless communities, women who are suffering from drug addiction, sex workers, and there is no problem. They may not have access digitally to all the things that you and I are privileged to own, but they know when that hub's going to turn up, because it all gets broadcast by word of mouth, and they are really, really appreciative of them. So I think it's not one size fits all. And what I'm really keen that the integrated care systems do now is look at their population needs and say, okay, we need to do this, this, and this. And they're going to be different in the rural setting compared to the urban, compared to the coastal deprived. And we're not going to be able to sort of direct women who are travellers or homeless to necessarily certain places, but we can actually provide them with access and also information. And I think the information bit is really, really important.
Yeah. And of course, a big remit for primary care there in terms of the information and the empowerment.
Yes.
With the women's health hubs then, have they already been rolled out in each of the ICBs?
Of the 42 ICBs, we know from the last tranche of data that 39 of the 42 have got a health hub up. There are more than 39 because some integrated care boards have been really at the vanguard of progress and have said, okay, well, we need different models as well to suit our populations. And I've tried to visit as many of those as possible because we need to encourage that. And now I think the challenge is scaling up against a financial backdrop of extreme austerity. This week, I wouldn't have been saying this if we'd spoken 2 weeks ago, against a backdrop of enormous change. But my other irritating character trait, apart from being very impatient, is being an incurable optimist. And I do think that every time you have a reorganisation and a crisis, you can find something good to come out of it if you you think positively about it. And to those ICB chairs and finance officers locally were saying, well, we can't afford this because you're not giving us any recurrent funding. My message to them is, I don't think you can afford not to work towards piloting or scaling up women's health hubs for all the reasons I've said.
Mm.
And there is a need to do this. So, if we were to speak again in a year's time, Rhiannon, we might even say that the reorganisation that happened and hit the newspapers so dramatically just last week might actually have been a saving grace in terms of how we roll this out, because we've got to think differently. And in the same way as I'm saying, it's not that secondary care or primary care have got it all wrong, but we've got to have a left shift away from the hospital and away from the disease-based NHS towards the community and the prevention piece. And it may well be that this reorganisation gives us an opportunity to make progress with that, and for more people to try the health hub model and realise that it actually is very valuable for them.
Yeah. So we're talking, of course, about the announcement very recently, as we record, that NHS England is effectively being merged with the Department of Health and Social Care. So it will definitely be interesting to see how it pans out.
Yeah, and I very much hope that during that reorganisation that we'll get lots of senior clinicians, junior ones as well, helping to reframe the new world, because I think so often policy makers are wonderful at what they do, but sometimes I feel that we should have had more clinical expertise or comment or input at an earlier stage. And we've also got to think very radically, I think, about how we analyse our data. Because at the moment, of the 600,000 women waiting on the list, on the gynae waiting list at the moment, we know that over 85% of them, as I said, are not going to need a hospital admission. Interestingly, the data comes from when you do things to women, I'm sure it does to men as well, in a health episode. But really what I would like to know is what happens when the next 100 women have gone through the outpatient clinic. So how many of them were there for period problems and have been managed medically with either the contraceptive pill or tranexamic acid or mefenamic acid or ibuprofen? How many of them needed something like a Mirena device? So that may be captured because that may be a procedure, but not always. And how many women came in with menopausal problems that we were able to provide them with a script for if they needed HRT or some form of other therapy? We just don't have that information. So we have to have a mind, and we have to ask the question: why don't we have that information? Because our service has been so predicated by doing things to people in secondary care and then generating a fee from that. So if 85% of 600,000 women are not going to be hospital admissions, then we've actually got to collect the data about what we need for them. And there are very good examples from some of the health hubs down in Croydon, where there's a urogynecology specialty centre. They've halved the number of women waiting to come to gynecological outpatients for investigations of their urinary or anal incontinence. And they've done it by providing physiotherapy and easy to access apps on phones for women to undertake exercises or monitor what's happening with their bladder. I mean, what an incredible step forward that, in fact, so many women then get treatment almost immediately. They're helping themselves or they're receiving medications which can alleviate it, and they're not sitting on this long waiting list, getting worse, becoming less able to get on with their day-to-day life. So I think that's really important. And that's before we even talk about the mental health issues associated with chronic disability, from non-life-threatening but really disabling problems.
You've just given a really nice example there, and obviously you have a great bird's eye view. Do you have any other best practice examples that our listeners might be inspired by?
Well, that's a very good one. I love some of the virtual work that's been going on. The Tower Hamlets models I was telling you about, where they've dramatically reduced the number of people going into Whitechapel or Mile End Hospital. And of course, the feedback from their clients or the patients is fantastic. Oh my goodness. The other things I think we've got to get away from is this insistence on giving people follow-up appointments. If we have patient-initiated follow-up, whereas I say, look, I've sorted that out, Rhiannon, I hope you get on well with this. You don't need to come back and see me routinely, but if you've got a problem, This is the link to come to. The reason why women don't want to be discharged from secondary care clinics is because they have spent so long or taken so much time to get there, they don't want to lose it. I mean, I was talking to one on a virtual consultation on Tuesday morning and said, oh, no, please don't get rid of me now because it's taken me so long to get here.
So long. Yeah.
I reassured her that she can get hold of me or the service by linking in, and I doubt whether she'll need to. We've got to change the way we're going about things. That's one way. In the northwest, up in Liverpool, they've done some really good work with co-commissioning, so commissioning from local authorities and other organisations, so that instead of me telling you, well, because you've got painful heavy periods, I can fit you with a Mirena device, for example, or another long-acting reversible contraceptive to help with your menstrual problems, I can also do it for contraception. And I can also do it for the endometrial protection part of your hormone replacement therapy program. But so often the commissioning has been, oh, we're commissioning menopause, we're commissioning menstrual disorders, we're commissioning for contraception, and the things don't meet up. And that brings me on to one of my really big hobby horses, which is how contraception, which is the single most cost-effective intervention in the whole of healthcare, and does so much more than prevent pregnancies, does so much more in terms of menstrual health, HRT management, I would argue mental health as well. And most importantly, and the things that people tend to forget, is that we have a maternity crisis in this country, and every couple of months we have another, in quotes, scandal. And one of the things that we could do to really reduce the complexity and the complications would be to ensure that every woman who has delivered a baby, before she goes home, so baby in one arm, and then in the other arm she's either got an implant or a coil in the uterus or 12 packets of desogestrel or a bridging injection of Depo-Provera before she goes home. Because many women don't realise that it's quite common to ovulate 21 or 28 days after a baby's been born, even if you're breastfeeding diligently and you don't have periods. And this, I think, really came to the fore during the COVID lockdown, that women were coming back pregnant again in a very short intervals. And we'd known for decades that if you space births by 18 to 24 months, you reduce every single complication of pregnancy, from prematurity to preeclampsia to postpartum hemorrhage. Really, really important. So I'm not saying I don't want women to get pregnant. I'm wanting them to have an interval between two pregnancies, which minimises their complications. And of course, they're also, coming back to the economic argument, the most expensive complications. You know, when you deliver premature twins, you've got neonatal services. So there's all sorts of other repercussions. I also think that, women are sort of almost captive, aren't they? They're a captive audience when they're coming into a maternity unit or a birthing centre, or even if they're having a home birth, where they're a captive audience for those healthcare professionals to use that contact, make every contact count, to say, look, we can help you with this. We're not trying to prevent you having any more children. We're just saying, give your child the best chance and you the best chance to have the best early years. And I think that's something that for years and years and years we've known about this. And we never have, if you like, the bottle, shall I say, to say, okay, we're going to do this. We're going to make sure this happens because it is going to be so beneficial, not just to one, but to two patients and probably whole families as well.
Yeah, it's interesting actually that you talk about the sort of the fact that when women are having just given birth, or in fact for their entire pregnancies, they're in such a position where they're having much more contact with healthcare professionals. They're often very receptive to information and things like that. And in fact, one of our most popular learning modules last year was with some learning points from the Embrace reports around maternal equity. And I remember one of the points in that, I think it was referring to vaccination or, health advice, was exactly that point, was that, this is a really receptive point in a woman's life, a lot of contact with professionals. And so it's a great opportunity to make those changes and have a real impact on people's life.
I agree. And we do have to make every contact count. And as I say, and when you've just said very correctly that it's a one time when women have lots of contact and they're not actually sick for the most part. We really do need to maximise that interaction for everybody's benefit.
Mm. I actually heard you speaking on another podcast, and you were talking about the impact of women's health during pregnancy and the information it can reveal later. And I think you were talking about, for example, someone who experiences preeclampsia during pregnancy being much more likely to go on to develop cardiovascular disease earlier than somebody who doesn't. And the idea of being able to get upstream of problems that women might experience.
Yeah, and this comes back to my sort of making every contact count. And we've known, again, for decades that pregnancy physiology in women is a little bit like putting on your L plates when you're learning to drive. And you get enormous insights into what's likely to be going to affect that woman in later life. So if you develop gestational diabetes during pregnancy, it's guaranteed that you're going to be a diabetic by the age of 50. And also, as you just said, preeclampsia and other disorders, all of which are pregnancy-induced hypertension, all of these things that are definitely going to increase the risks of heart disease, which I mentioned at an earlier point in our discussion, are going to be the things that really do for women in the long run. And it's interesting, my particular interest in this came out of my recurrent miscarriage work, where I noticed that the women who had repeated miscarriages and we'd found they had pro-thrombotic disorders like the phospholipid syndrome or other clotting problems, that they were having, or they were in later life when we caught up with them to see what had happened to them, they were having an onset of cardiovascular disease 10 years earlier than the woman next door who'd not had repeated miscarriages for that reason. So there's masses and masses of data that we can use to predict and to start to prevent other problems of delivering. And what's always puzzled me is that every maternity unit I've ever walked into collects a myriad of data throughout the pregnancy and the immediate postpartum period, and then we just ignore it. And I think that's not sensible. What I would like to do is to have a postnatal review for every woman in which we can talk about the contraception and the vaccinations. I think 6 weeks is too late, actually. And some would say it's too early, or perhaps we need to just do more about understanding that we need to help women in the next stage of their life course when they've got a young baby, and that we can learn so much from them and about their future needs. And we know we haven't really talked much about mental health but perinatal mental health is dreadful. We know that 1 in 5, or perhaps it's 1 in 4 women are going to get an element of depression. That's going to also identify a cohort of women, a growing cohort, who are likely to need mental health services later on. And I think you mentioned the Embrace report. I mean, what's so awful is that suicide in pregnant women is now a leading cause of death. About 20 to 25% of those maternal suicides are teenagers. I've got quite a robust character, but if one of my daughters had killed herself as a teenager as a result of pregnancy, that would have broken me.
I know you've said in the past around there is only so much that the healthcare system can do to improve the lives of women. You have the whole rest of society as well, and it does speak to a lack of support.
As I often say, you can't expect the Department of Health and Social Care to crack this solo. They can provide about a third of health, but then we've got to have the DWP, and we've got to have the Home Office, and we've got to have the police, and we've got to have the Department for Education. I mean, that's another hobby horse of mine, is if we taught young girls and young boys from the age of 10, which is the average age of starting periods now, if we taught them carefully about periods, what to expect, what's normal, what's abnormal, and we need to teach the boys as well, we would dramatically reduce the number of women who develop endometriosis, because you don't wake up one day with endometriosis. It develops over a period of time because your painful, heavy periods have been neglected. And there's so many things that we could do. And, 400,000 women every year will become menopausal. Since we know that if you menstruate, you're going to become menopausal, some earlier than others, that needs to go into the teaching as well, so that these things are not a surprise.
Yeah, I've definitely noticed over the last few years, menopause particularly, I know within our workplace, there's menopause training and awareness and things like that. And I see it talked about a lot more. I feel like that really is on the agenda now. It's interesting that you talk about contraception being an area that's been overlooked, that maybe needs to be bumped up the agenda.
If you came to see me and I didn't ask you about your past operations or medical history, and I didn't ask you about what drugs you're taking, what allergies, I think you would rightly think I was being a bit sloppy. But why don't I ask you 2 questions? Even if I'm an orthopedic surgeon, why can't I say to you, okay, sorry about your foot, Rhiannon. How are your periods? Are you still having periods? That's a tactful thing to say, isn't it? Because you may not be, anymore? And if the answer is yes, I am having periods, then all you need to say is, do they ever stop you getting on with your day-to-day life? And if the answer is yes, they do, okay, well, that's not normal. You need to go and get some help. So I'm not expecting them to be able to sort things out menstrually, but if every GP did that, we would dramatically short circuit these waiting times and the understanding. So once again, it all goes back, doesn't it, to the training and the understanding of what is normal and abnormal. Historically, I think women have been expected to just literally suck it up. That's normal. Your mum had painful, heavy periods and became anemic and was always bedbound, and that's what's got to happen. So that's normal. And it's not. So the Wellbeing of Women Just a Period campaign has done a lot to publicise talking about periods. I in no way want to detract from the menopause interest, but if all employers thought about menstrual health as opposed to women being off sick on a regular basis with problems that are a bit vague, we would move a long way towards more productivity and happier people.
Yeah. I'm very interested by the idea of your menstrual health being really a marker of your overall health.
Regularly, I see women who are feeling, they are tired all the time, or feeling exhausted, and they usually sort of rationalise that by saying, oh, yes, well, I've got school-age children and I'm caring for my mother and da-da-da-da-da, and I've got a busy job. You do their blood count and you find that although their haemoglobin is sort of okay, they've got no ferritin in their system. They've got rid of their iron stores. And when you give them an iron infusion, they become a different person. They say, wow, I feel so much better. And this is so simple, and we need to factor that in as well. But then just explaining to a woman that, okay, she may not have been hemorrhaging, but if she loses more ions from her stores every month than she's able to digest from her diet, then of course she's going to get lower iron stores, and they really do affect health. And it's a bit like menopausal women who they come with telling me they've got brain fog and they've got problems and they're worried about stuff, or they think they're getting dementia or whatever. And you can realise that they are perimenopausal. And you say, now, tell me about your sleep. And then they look at you and say, oh, how did you know? It's absolutely awful. I said, well, yes, because I've been there myself. It's awful. These are things that really affect people's lives. I mean, if you got, if your sleep totally disturbed, that feeling at 4 o'clock in the morning, and you're thinking, oh my God, this is the best I'm going to feel all day because it's just going to get worse.
Yeah. The nice thing for our primary care listeners is that the life course approach that you're talking about and the predictability of the issues that women are going to face is that primary care really do have the longevity of that relationship with their patients. So it's somewhere that they can really hopefully make a difference.
The other thing I think we need to touch on, and we're going to take some brave clinicians to do this, is we've got to do something about obesity. And that gets me into an awful lot of trouble when I'm telling my miscarriage ladies or my menstrual problem ladies that, a lot of this would be helped, not cured necessarily, but helped by losing weight. I think that there is a problem in that society has sort of normalised this. We've even changed the criteria for BMIs and how we classify them. I know how difficult it is to lose weight for some people, but I think we've got to address this because it really is affecting so many aspects, and particularly in maternity. But it's a very difficult one, isn't it? And we've got the food lobbyists, and we've got to do something about it, though, because it's going to be the undoing of us all.
We had a guest on the podcast a couple of months ago talking about obesity, and because, it's definitely, I think it's a worry for GPs how to address it sensitively.
Well, I know that some of my junior hospital colleagues are very reticent to make any comment about BMIs because they know that they'll get complaints about them. So I suppose you have to be as old and long in the tooth as me to sort of tackle some of those things. I get into trouble about it too.
You've said the problems for women in later life, you talk about cardiovascular disease and dementia and things, but I wanted to ask you a bit about cancer and cancer diagnosis because we're running this editorial campaign at the moment around earlier cancer diagnosis. And I wonder what your kind of thoughts are. What's the state of play in terms of, we talked about some of the inequalities in cancer diagnosis. Is it the case that women are diagnosed later than men? Is it very variable?
Well, I mean, let's talk about sort of gynecological cancers and then other cancers which are not gender specific. So cervical cancer is now a preventable disease. And yet this year, more young women are going to die of cervical cancer than will die through pregnancy and childbirth. which when you consider that there is a vaccine there, which is getting cheaper and cheaper, and colposcopy screening, it is really sad. We can't rest on our laurels again in the UK because cervical screenings at a low, and it's women from marginalised groups and ethnic minorities that are the poorest attenders or the poorest take-up. There's a rising prevalence, almost an epidemic of endometrial cancer, and that is absolutely directly related to obesity because the estrogen that gets stored in the excess fat then is stimulating the uterus. The incidence of lung cancer has increased in women, both in smokers, which is, again, often socioeconomically determined. I think they do have slightly later diagnoses. I'm not aware of whether colorectal, which is another big problem, has got a sex differentiation in presentation or in treatment outcomes, but I must look into that. It's an interesting point. And then, of course, there's breast cancer. One of the things that I think has been really important to emphasize is that breast cancer is incredibly common, 1 in 8 women. This is a massively high number, but screening is so valuable because we know that very early stage breast cancer is treatable. I've had breast cancer twice, and I know that's not going to kill me because I was treated at a very early stage. And, okay, it wasn't particularly nice, but I'm back on my hormone replacement therapy because that actually keeps me fit and healthy and bouncy, and my bones don't creak and my joints don't seize up. And I've made that decision for me that that's the best way for me to go forward. But I think of my reflection on the last 20 years or so since the Women's Health Initiative study was published in 2003 and the other big one. That was probably the biggest disservice we've done women in the last 50 years, was deny them the benefits of hormone replacement therapy. I'm not saying it's right for everybody, but for a lot of women, it's the difference between seizing up and becoming quite frail and not able to, just losing their mobility and their independence. And there appears to be good data that it's protective for cardiovascular disease. It's indisputably protective in terms of osteoporosis. It's one of the very best bone builders. And there is some data that suggests that it's going to change or improve the chances of dementia or postpone it. Dementia, I think, and degenerative diseases are important to understand. I hadn't really appreciated until I was in this role and talking to stroke and dementia clinicians. The cardiovascular benefits are so important. But also, for example, women who present with Parkinson's disease tend to present with tremor as a first symptom, whereas men present with problems with their posture and their balance. There's all sorts of things that become gender specific, and very interesting articles published by the McKinsey team, as I'm sure you will know, last year, about the money that one could save if we close the gender health gap globally. They very kindly did some analysis for me and demonstrated it was a massive amount of money we could save in terms of just the UK in sterling, something like 20% of the whole NHS budget currently. Marvellous stuff there. But the other thing that I thought was really interesting was that they were demonstrating that 5% of the poor health in women, 5%, that's 1 in 20, is due to gynecological or gendered disease, and the other 95% is all about things that affect women differently or disproportionately.
That's quite surprising.
It is, isn't it? And included in that are some of what we would call the gynae things, like premenstrual disorders. But migraine, for example, is primarily in women. Autoimmune diseases, primarily in women. It's really interesting. I think the figures are about 40% or 45% of ill health is due to disorders or diseases that we don't think are gender. There aren't differences in gender. But actually, when you look at it carefully, that's because no one's done any research into it. One of the other things I think that the Women's Health Strategy has helped to push forward is, for example, the NIHR, National Institute for Health and Research, and their funding bodies now won't accept applications for funding for proposals or studies that don't have sex disaggregated data. And that's a big step forward. So you're not even going to get into we'll circulate your proposal for assessment if you haven't fulfilled some of those criteria. And I think that's really important as well. So there are all these things that we've got to think about. But as I say, the 5% of disease being due to women-specific issues, I thought was very, very striking. And then, as I say, disproportionately or differently. And we talked earlier about heart disease and the way things that present. There's a lot of disorders that present differently in women. Once you've been made aware of it, it's easy to identify.
Yeah, absolutely. Well, I mean, we've covered an awful lot of ground, Lesley. Thank you. What I'd like to ask you to finish is, what would be the key points that you would like our primary care listeners to take away from this and that they can really reflect on, take into their practice?
That women's health is really important to view as part of a life course, that your health in every decade of your life impacts on the next one. Women, as the child bearers, are then going to influence the next generation, and the transgenerational transmission of genomic and epigenetic and all those other things that are so important. That pregnancy could be made so much less risky and so much improve the outcome so greatly if we thought about women's health before they became pregnant and got them to optimal, and that we use their journey through pregnancy as a traffic light to help us identify what they might need later. But most importantly, to recognise that if they do nothing else, every time a girl or a woman comes into their surgery, to ask them about, do they need any form of long-acting reversible contraception and what their periods are like. If we achieved that, I think we would revolutionise healthcare for women, because they are so important. Because the moment you start menstruating, you're, give or take a year or two, you're fertile, aren't you? So if you have the menstrual health teaching for everybody, and everyone's asked about it, and the contraception quiz, we would do dramatic things. And I think most of the other problems that women experience later on will become very evident then, because you've got a different mindset that you're thinking about in the way they're thinking about things. So I would say menstrual health not disease, and contraceptive health is also really important as well.
That's a brilliant thing to leave us with to reflect on. It's been great to have you, Lesley. Really appreciate you joining us. So don't forget that you can claim CPD credits for listening to this podcast. You just need to go to our website, mimslearning.co.uk, and complete the podcast module there. I've been Rhiannon Ashman. My guest today was Professor Dame Lesley Regan, and this episode was produced by Till Owen. You've been listening to the MIMS Learning Clinical Update podcast, and I hope you'll join us again next week.